I'd like to begin by thanking Dr. Resnick and the Learn Network for inviting me to present at this Grand Rounds presentation. I'll be presenting on the application of sustainability frameworks and assessments in rehabilitation and sharing the results of a 4-year implementation project that we've done at the Shirley Ryan Ability Lab. To start with the basic learning objectives that really relate back to my agenda, that I'll be starting by summarizing some sustainment definitions and models. Although if you were able to watch Dr. Chambers' talk last week, that was a really great summary and gave a lot of great details. I'll be talking about sustainment within the implementation process. I'll be describing some different sustainability assessment tools, and then I'll provide my example of sustaining in practice. So here, really learning from the wisdom of others, and as Dr. Chambers presented, that it's really important to think about how we're going to define maintenance versus sustainment, and then sustainability as well. So maintenance is the extent to which a program is maintained or continued over time. And sometimes it can be confusing because you might think about sustained maintenance at the individual level. So I do a lot of physical activity research, and we want the individual to maintain their physical activity. So the long-term effectiveness of your evidence-based intervention. We also are talking about maintenance at the setting level, that the setting needs to continue implementing the EBI. And it's really important with maintenance, I think, to conceptualize how you're going to institutionalize your program or practice. How are you going to make it routine in your organization? The problem with institutionalizing something is that sometimes that makes it static and difficult to change. Sustainment has been formally defined by Moore and colleagues who developed a comprehensive definition of sustainability and sustainment. And they define it as after a period of time, typically at least 2 years, which is a lot because research studies frequently don't last that long or they aren't funded for that long. But after at least 2 years, the program or clinical intervention and or the individual behavior change, both the clinician's behavior change and the patient's behavior change are maintained. The program and individual behavior change may evolve or adapt. And that's really important, I think, that when we think about our programs, but also our individuals, when we think about, physical activity behavior change. My physical activity needs to adapt seasonally, for example. So how do we make sure that we keep the fidelity of something while evolving and adapting as needed? And it also needs to continue to produce benefits for the individual and or the system. And I'll talk a little bit in my example about how we can make sure that our programs are benefiting the systems as well as the individuals. Sustainability, I am starting to kind of realize, is really the potential for sustainment. And I like to think of sustainability as being measured earlier in the process. So it's whether something has the capacity to be sustained. Dr. Chambers also mentioned spreading and scaling out, and this has been really important for us as we take one small clinical program and think about how do we spread that to other sites. So you're implementing the program or practice in a new but similar setting, and it's related to diffusion of ideas and dissemination of ideas, but you have to make sure that you're spreading with fidelity and spreading to new contexts. In rehabilitation, we have academic rehabilitation centers, we have smaller PT clinics, Joe Blow's PT place on the corner. We have these other PT places that are owned and coordinated by private equity groups. So there's a lot of different context within spread. And then there's also scaling out, which would be expanding an evidence-based intervention to a new population or delivery system. We can accelerate translation potentially by borrowing from prior effectiveness trials and other populations. So for example, is a physical activity intervention in people with low back pain the same as a physical activity intervention for people with stroke? How can we borrow from those trials? Dr. Chambers presented the dynamic sustainability framework, which I think has been very important for me in terms of in my project and my research, is to understand that the voltage drop is not inevitable, but that change is what is inevitable. So there are constant changes in our interventions because there's new research in rehabilitation that's published, every week, there's a new email that comes out with our, publications and press. There's new contexts, and the context change, our organizations change, our environment changes. We have pandemics that start and then they slow down and then they come back and then they slow down. Policies change related to rehabilitation payment and reimbursement all the time. And so that requires constant evolution for our program to be sustained. We need to have ongoing optimization of our interventions across all stakeholders. So based on the evidence, based on new stakeholder involvement, we also need to make sure we understand that the program maintenance is most likely when there's a good fit with the organization. So as organizations change and organization priorities shift, we need to make sure that our programs shift with them. Dr. Chambers also presented on the research and publication here from Dr. Shelton on extending the REAIM framework to enhance sustainability. And I'll go into a little bit more detail on REAIM as a part of my evaluation of our program. But what I really liked about this new extension of REAIM is its focus on equity and costs for successful sustainment at the population level. And I think about equity and costs in particular related to physical activity related research, because so much of our research is done in these academic medical centers, and our patients are not always, or our research participants are not always reflective of our patients, and they're certainly also not reflective of patients all over the country or in different communities. So we need to figure out, as we kind of go from maintenance to understanding sustainability and the evolvability of our adaptations, we need to plan for that evolution, plan for fidelity, consistent adaptations, and ongoing refinements. And so I'm starting to try to work through what that means for my interventions and how I document why and when we're making adaptations. And as Dr. Chambers noted, it also may involve de-implementation, which is just good to keep in mind. So over the course of the speaker series here through Learn, we've really seen some amazing presentations, I think, on different process models and explanatory frameworks related to implementation science. But I did want to just share a few in terms of to make sure that everybody's starting at the same place when we get to my example. So sustainment fits within the process of implementation. The EPIS model is one process model that also includes explanatory factors in each one of the stages. In the EPIS model, they define sustainment as a goal to realize the continued benefit of an implemented practice or program. So that is interesting because it talks about the goal to realize it, and how often when we start a project do we think about our sustainability goals. We all start a project assuming and wanting it to sustain, but we don't always conceptualize that early on. EPIS also talks about the ongoing structures, processes, and supports that need to be in place for sustainment, and it talks about adaptation. So there's this theme now coming through about how important adaptation is and ongoing processes and supports. However, I want to talk a little bit more about the knowledge to action cycle. That's the process model that I use most frequently in my research. The reason that I like the knowledge to action cycle is because it really does a nice job, I think, of showing this knowledge, the knowledge synthesis triangle in the middle, that because so much of rehabilitation research is still at this knowledge inquiry and knowledge synthesis stages, so we can't always jump right to sustaining any new intervention. But you can see here that the knowledge to action cycle does outline, kind of overlay with EPIS. So all of these process models are kind of going through the same steps. I just like the knowledge to action cycle because of how it breaks down the processes within each step. But the knowledge to action cycle also has this important sustaining step where it also would draws attention to assessing barriers to sustainability, tailoring interventions to these barriers. So don't just tailor your interventions to the barriers that you're discovering in the preparation phase, but continue to evaluate these barriers as your program is sustaining and tailor interventions to the sustainment barriers. It also highlights the requirement to evolve and adapt and to monitor ongoing knowledge use as you go through the cycle repeatedly. And it mentions the importance to evaluate both initial and sustained use. And one of the things that it highlights is that it's best to consider sustaining early and throughout the knowledge to action cycle. And the final kind of comparison that I wanted to provide comes from Dr. Chambers' work with the dynamic sustainability framework. And I wanted to highlight this table from his article where he contrasts the static views of sustainability with the dynamic sustainability framework. And I thought this was important because a lot of times when I start talking about my research and my project, particularly in rehabilitation research audiences, they come from a traditional randomized controlled trial kind of mindset. And so it makes them very uncomfortable that I might change what I'm doing in the middle of my study. But if we think about adaptation and just being sure that we're tracking those changes, it's important for us to know that, the adaptation really isn't inevitable. We just need to monitor it and make sure that we guide our adaptations by evidence. This review of the evidence, there's initial review from efficacy studies, but there's ongoing new evidence developed. For example, in my project that I'll talk about in a little bit, we're doing research in Parkinson's disease and physical activity and exercise, and a new clinical practice guideline came out last month. And so as there's new and developing research, we can tailor our program to really highlight and complement the new research that's coming out. One of the things that I really liked about this table as well is it talks about staffing issues and turnover in projects. And when a randomized control trial, you really fear change and you want to have as much consistency in the assessors, as consistency as possible. But when you're doing implementation work, you really want to investigate and kind of control for and plan for those changes in staffing because they are inevitable over time. And, so we really are trying to plan for them from the get-go. Next, I want to talk a little bit about sustainability assessments before I get into my example, because this is also, I think, going to set the stage for how I'm going to discuss how we used our sustainability assessments to change our processes and procedures throughout. So I'm going to talk about 3 different assessments, repeating REAIM. I'll talk about the NHS or National Health System Sustainability Model, and I'll talk about the clinical sustainability assessment tool. So one of the most common ways to assess sustainability is really just to repeat your REAIM evaluation. And REAIM stands for Reach, Effectiveness, Adoption, Implementation, and Maintenance. And this, the full reference for the Shelton article is before, and this comes from the work of Glasgow and colleagues that were interested in reach the number, proportion, and representativeness of the individuals who participate in the evidence-based intervention for REACH. So one can look to see whether the number and proportion are growing over time. Are you capturing more referrals, or is there program growth? Is the effectiveness being maintained and over time? If you measure the effectiveness in year 1, is that the same as year 2 and year 3? You could consider if there's, as more participants come through, can you measure any heterogeneity in the effects of your program? Adoption would also relate back to program growth and understanding whether new clinicians are adopting your program, or perhaps are people stopping to adopt it? Did they start out strong and then as the program goes, people kind of fade off and referrals decrease? We can understand implementation fidelity, as well as adaptations that might occur over time, and then maintenance. And what I liked here, Shelton really, she suggests maintenance should be measured at 6 months, and then also at least a year afterwards and ongoing. And that kind of contrasts the Moore article, which said we should really think about maintenance or sustainability at least 2 years and beyond, but really starting to look at longer term maintenance. The NHS Sustainability Model, that one is an interesting model, and we found this online. We went through my research team and I went through a knowledge translation training called the Knowledge Translation Summit, put on by the Academy of Neurologic Physical Therapy. And so we were first introduced to the NHS Sustainability Model there. Ian Graham, who put together the knowledge to action cycle, he kind of introduced us to it. And it's really interesting, although not published in the peer review literature space, but we did find it to be very helpful. So I want to share what we found. It was put together back in 2010 is when their workbook is developed. So it's old. And I guess old now, it feels old, but it was put together by 250 experts. They created 10 factors in 3 different categories. So there was a rigorous process, I think, to having these expert stakeholders come together to develop the NHS sustainability model. They developed a quantitative survey, and it's a model that's being used in the English, and some in the USA, some in Sweden and Norway, some in Canada. And the goal of putting together the sustainability model was to identify key factors which support or hinder sustainability and innovation. So there are 10 factors and there are 3 domains. The 3 domains are staff, process, and organization. And the 10 factors are monitoring progress, adaptability, credibility of the benefits beyond helping the patients. So I mentioned kind of a teaser earlier about how are you benefiting the organization as well. For staff, the domains are training and involvement, the staff behaviors, the senior leaders, and the clinical leaders. And for organization, the 2 domains are infrastructure and fit with goals and culture. Now, one of the things I really liked about the NHS Sustainability Model is that their program booklet provides a cutoff score, that if you score greater than 55, it states that you should have optimism towards your sustainability. And if you're less than 55, that it suggests that you need to take action to improve sustainability. And as a physical therapist clinician, I really like my cutoff scores because I like to be able to set goals based on them. So I really liked that. But what I didn't like about the sustainability NHS model and its assessment tool is that this table here is an example of a score, and the maximal potential score for each of these items is a different number for each one. So they must have done some psychometric testing that isn't in this particular booklet or the details of it. But so you've got maximum scores that range from 7 to 15, and they're calculated. It's a little bit I'm a little bit unclear on how they're calculated, but so they are giving this hypothetical example in light gray, and a with black being the maximal score. So I want to contrast that to the program sustainability assessment tool and clinical sustainability assessment tool. Dr. changed these last week, and these are really great tools. They have 8 domains and 7 domains respectively. I do find when we looked at whether or not we were going to use these tools, we did use the clinical sustainability assessment tool. And it is really interesting, I think, to look at how the questions and how the domains differ between sustainability of program. So this is more in the public health space, and sustainability of a clinical intervention. So they did a really nice job, I think, of kind of having different domains in those 2 different spaces. So for those here, I think most people probably listening in are working in the clinical space. The clinical sustainability assessment tool is really helpful. I put together this table though to kind of show the overlap between the 2. So I mentioned the 4 domains of the NHS Sustainability Model and staff involvement and training, behavior, senior leadership, and clinical leadership. This is summarized in the CSAT. They have 7 domains, and 2 of them are engaged staff and leaders and engaged stakeholders. For processes for CSAT, they have 3: the implementation, training, monitoring and evaluation, and outcomes and effectiveness. And I should clarify, I am the person who split up the CSAT 7 domains into these 3 domains. And part of that is that in my mind, these 3 domains of people, process, and organization make a lot of sense and are kind of helped lead me to actionable examples. And for organizations, the workflow integration and organizational readiness. So to kind of summarize our sustainability assessments, the NHS Sustainability Model provides this very nice cutoff, and answering the questions I'll show later really informed how to improve. The CSAT, it was recently published just last year. The article came out on its reliability and validity, and it's really nice to see that in the peer-reviewed space. It's a little bit less actionable right now. There's not a cutoff score, but the fact that they're working on this right now, I think I assume that those things will come from that group, and I'm really excited to keep watching it. So thank you for bearing with me for that review. For the remainder of the talk now, I'm going to talk about our example, sustaining in practice. I want to kind of reference this as a team effort from an entire research team, and because it's a 4-year project, there were a lot of people involved, and I'll make sure that I list them later. But I first have to acknowledge Jillian McDonald. She's a research PT in my lab, and I think my first sustainability note was how important it was to include her from the get-go. When I approached leadership at the Shirley Ryan Ability Lab and asked to start what we were calling a proactive physical therapy program for people with Parkinson's disease, they said, you're a postdoctoral fellow. And at that time, I was just flex staff in the organization, although I'd worked there for a long time. And they said, you need to include a staff physical therapist in this. And so they partnered me with Jillian, and it has been a very productive partnership. And so that was, I took their suggestion as who to involve, and that was really great. So again, I will kind of bring us back to our knowledge to action cycle, which is, and starting at the funnel with where we started in this project. And I should say that this project started in the fall of 2015. That's when I began meeting with leadership. And at that point, there were some clinical practice guidelines. The first one is the COOS 2014, a clinical practice guideline for people with Parkinson's, came out in Europe that said that physicians should consider referring people to Parkinson's disease early, soon after diagnosis, for assessment and education and advice, including information about physical activity and individually tailored exercise recommendations. So here's a clinical practice guideline, albeit from Europe, saying that people with Parkinson's should go to PT soon after diagnosis. We were able to look at our own practice and see that we were not getting those referrals at our organization, or really, we did some large data set analyses. It's not happening very much in the United States. We are getting the second layer of getting Parkinson's specific PT for people who are experiencing balance and motor function problems. We see those patients all the time. We had great relationships with our neurologists, but we weren't seeing patients early. So that to me is kind of our no-do gap, going back to the knowledge to action cycle. I do want to also mention how we, when we look at the knowledge to action cycle, we see the bi-directional arrows where you're always going back and revisiting what new evidence arises. And there is this new APTA Parkinson's CPG that was published just last month. So I've now layered in this slide, I know it's a little bit busy, but I took the knowledge to action cycle in the middle, and we've talked a little bit about our no-do gap. And then on top of that cycle, I layer explanatory frameworks. So I layer this consolidated framework for implementation research in our preparation phase. I layer in the expert recommendations for implementing change at our selecting and tailoring our implementation interventions. The Rehab framework we use for evaluation. And then I'm thinking about both the NHS Sustainability Model and the CSTAT for sustainability, but importantly, kind of considering adaptable sustainability strategies and the dynamic sustainability framework early on in our process. So with our kind of first cycle through, when we identified barriers and the implementation strategies that we wanted to use, we obviously, we had a much bigger table with more detail in it, but a couple of things that I want to highlight is that our physicians felt like they didn't know what we were going to be doing with patients early in the disease process. So we had to create and define a care path for them. The individuals, the clinicians had they thought that it was important to exercise, but they also thought that people with Parkinson's might not need PT early. And they thought, well, we don't want them to, the patients, they said, are afraid of getting sucked in, that we're going to suck them in. If they come to PT soon after diagnosis, that they're going to be stuck with us 3 times a week for the rest of their life. And so we had to explain and develop marketing materials and presentations and trainings to make sure that if somebody was referred to us soon after diagnosis, that they knew that that is not what would happen. We identified that there was good compatibility. We had lots of individuals in our organization that really wanted to work with this project, but we did have some EMR and workflow challenges and process challenges, like for scheduling. There were some outer setting concerns related to reimbursement and convenient locations. And so we wanted to kind of start slow. We started at just one site. And then we wanted, which was our downtown kind of flagship hospital-based outpatient neuro department. And we wanted to spread to our suburban sites in the suburbs in the future. And that'll be kind of the result of my sustainability in the 4-year project, is how we spread to those sites. So that kind of summarizes our initial strategies. In 2019, we were able to publish the results of our first year of the program. So in 2016, we actually saw a total of 28 patients. And we called those 28 patients afterwards to do a longer term follow-up assessment on them. So half of the people that we called reported that they were increasing more. And this is about 18 months after their evaluation. 50% of them were increasing more than they had before. Another almost 20% were exercising about the same. And then we had one person who was exercising less. That individual actually had also had a diagnosis of cancer in the intervening year. So I like to think, that there were extenuating circumstances to his exercise change. And we had 8 people that didn't answer the phone. So I want to make sure we recognize there's people who didn't respond to our quality improvement phone call follow-ups. They might be the people who didn't benefit as much from our program, but at least having this 50% was really great. We also saw that people were doing more different types of exercise. So with the new clinical practice guidelines coming out that recommend strengthening and balance training as well, it's nice to see an increased number of people doing those exercise types. So that's kind of our effectiveness evaluation. And that brings us to then, what are we going to do for sustainability? So first, we looked at sustainment. How was this being sustained over time? And so as you saw, that last article came out in 2019. So that's when we started then looking back to say, okay, now this program has been around. It started in 2016, 2017, 2018, and now we're in 2019. So we looked at how people sustain their increases in exercise over time. And here, I have to admit, my pie charts here are a little bit misleading, because this year 1 excludes the people that we didn't reach. But excluding those people that we didn't reach, in year 1, we had about 70% of people who said that they were exercising more. In year 3, we had 64% of people who said that they were exercising more. So similar self-reported increases in exercise. We had great sustained and growth in our program reach and retention. So over time, we went from 28 patients to 110 patients. One of the goals of this proactive physical therapy program is to get people with early Parkinson's to a PT to exercise more, and then to have them come back every 6 to 12 months. And one of the things we noted here was that actually then in year 4, of those 110 patients that came through the program, only 25% of them were repeat customers. So that was something that maybe we could improve, the retention of patients in this long-term delivery model, but the growth overall was very nice. In our initial paper in 2019, as well as in the McDonald et al. Publication that just came out in 2021, we published the results of our repeated re-aim evaluation. So of those 28 patients that we saw there, that was actually out of 38 people who were referred to the program. So in that first year, we had lost about 25% of patients between referral and coming in for a visit. Some of those were due to the inconvenient location of coming downtown. However, in 2019, when we looked at our referrals, we had seen 110 patients and 133 patients were referred. And so we are also similarly missing slightly less percent. We lost fewer people during that referral to visit time period. And then, I realized I was pointing at my screen and not this one. We asked our neurologist groups about how many newly diagnosed patients with Parkinson's that they saw in their clinics, so that we could better understand our reach to people at that level, from the neurologist to the PT referral. And the neurologist clinic had grown also between those years. So we're still not getting a huge proportion of all of the patients that the neurologists see. So that was something that we thought maybe we can continue to improve upon. Again, and depending on how, it's very interesting here now looking at how I've cut and pasted these graphs in together, but depending on how you calculate it, that first pie chart that I showed, we had 50% of people reporting more exercise. In 2018, we had 60% of people reporting more exercise. So our effectiveness is maintained. Our adoption grew, as you might expect with growth of the program. So we had an increased number of doctors that were referring, and I apologize, that part of this adoption slide might be a little bit more reach, but we increased from having 3 referrers to having about 8 different referrers referring into our program, which was nice to see. One of the things that I skipped over in this presentation was just talking about how we had to develop a new care path and care model to say that these patients that are coming in for this early Parkinson's rehabilitation, that they're really only coming in for just a couple visits. We're not sucking them into this 2 to 3 times a week. And so we found in 2016 that 86% of the people that we evaluated did in fact go to this shorter consultative model of care. Others were transitioned to a restorative model, which is also appropriate. You know, if somebody with Parkinson's disease has problems with walking and balance, they should receive more intense rehabilitation. And we had a similar proportion of people who were seen for this kind of consultative 1 to 4 visits, a short episode of care. And so about 86 and 88% over time. And then maintenance, I'm sorry, this is kind of, we're talking about the reach and adoption that increased, our effectiveness stayed the same, and our implementation stayed the same. So maintenance is just kind of repeating all of those things over time. So now our sustainability assessments. So this is the NHS Sustainability tool. That's the first example that I'll provide. And this, again, you know, this is taken straight from their booklet. They kind of have an online booklet that has the questions in it. And then people, for each of the topics, so benefits beyond helping patients, there's an A, B, C, or D response. And the person who's taking the test reads through those 4 A, B, C, or Ds and circles the one that they like the best. So this is an old school paper and pencil test. So here I'm showing you the results from our 3 sites. Our site 0 is our flagship hospital. And so you can see at site A, or site 0, we received an A, that we can demonstrate the change has, and in this case, the change is starting this proactive model of physical therapy. We demonstrated that the change had a wide range of benefits beyond helping patients, for example, by reducing waste, creating efficiency, or making people's jobs easier. However, at our 2 suburban sites where we grew, we received lower scores. So that kind of highlights some opportunities for improvement. A score of a B means that maybe we're reducing waste and making jobs easier, but that we haven't shown other benefits. And for D was that benefits are really only directed at helping the patients and not at the organizational level. So that gives us some knowledge about an opportunity for improvement to make sure that the organization recognizes what benefits there are to this program. For example, you know, these increased referrals that are coming in and there are more patients being evaluated, those are benefits to the organization, but we weren't making those clear to the leadership. Sorry, for credibility of the benefits, an A score is that their benefits of the change are widely communicated, immediately obvious, supported by the evidence, and believed by stakeholders, and staff are able to describe a wide range of intended benefits. And we did have some small opportunities for improvement there, that we were not communicating the benefits as widely as we could, even though they are kind of obvious and they're being supported, we just aren't making that, you know, we're not communicating that widely. Adaptability of the improved processes, we did okay on that one. I'm just going to kind of go through these a little bit quicker because you kind of, I think, hopefully are getting an understanding of how we're using the A, B, C, or D to inform us of what our opportunities are to improve our sustainability. The effectiveness of the system to monitor the progress was very different in our different settings, which was also really interesting to see. Kind of one of the opportunities for improvement here is that the information was not communicated, again, beyond the core team. And so we're seeing kind of a pattern here about our communication, and that the measurement system, or our EMR, was not set up to continue beyond the formal life of the project. And that's because we had Jillian McDonald was our implementation facilitator, and it's her job to do some audit and feedback. And if the project went away or the funding went away, that would go away. And I should also state, so that we were trained at the Academy of Neurologic Physical Therapy's Knowledge Translation Summit. And that was this project team of myself, Jillian McDonald, and one of our clinical physical therapy leaders, Laura Doyle. And we went to that training together. And then we received a grant from the Academy of Neurologic Physical Therapy. So Jillian's time at this point was being funded off a grant to do some of that. For staff, we can look through again. We see some A's. We see one that's all A's, yay! For clinical leadership engagement and support, we were really happy to see all A's there, but we do still have some opportunities and involvement here for our staff. At one of our sites, they were noting that the staff there were not involved from the beginning, and they weren't. We started at our flagellation and grew to our sites. And so we took that to say, like, okay, we need to involve the champions more in some of the processes. And again, we'll celebrate that one. And then for our organization, again, all A's, that's great. We fit with the organization's culture. Our organization really likes kind of novelty and evidence-based practice. And so they were very supportive, but we do have some opportunities for improvement in our infrastructure here that are, all of our staff were not trained in the program. Just the core team that was working on the project were trained. So we did have some things to work on. So overall, our sustainability score was, a 71 out of 100 as an average. That's greater than that 55 cutoff. We are optimistic for sustainability, but there are opportunities for improvement. We also then, after doing this paper and pencil one, that's when we actually learned about the CSAT. And so we did that one too. And it was really interesting to do them both. And so I'll talk a little bit about that. We have these are our NHS sustainability scores. So things like staff involvement and training, we got an 8.6 out of 11.4. So that's where I was saying before, like, these scoring systems are not intuitive. We got a 6.6 out of 11 for behavior. But you can kind of see that some of these are fairly low. Like that to me seems like an opportunity for improvement. For the CSAT, each one of the 7 CSAT domains is out of 7 points. We had 10 people take the CSAT. We did the CSAT online. So we are part of the participants in their study, actually. So they had all of our scores and data, but our averages were a lot higher in the CSAT. So 6.5, 6.3, our lowest one is this 5.7 out of 7 for monitoring and evaluation. That's very likely similar weakness that our implementation facilitator is funded on a grant. And when that goes away, how are our systems going to continue? Our EMR, we were able to change some things in our EMR, but not everything that we wanted to change. So looking at the two together, we can see some strengths that are fairly consistent between the two scoring systems. The clinical leadership here, we had engaged staff and leaders. That was also very strong in the CSAT. For processes, the outcomes and effectiveness was considered pretty highly strong in CSAT, but not, we do have some good credibility of the evidence in the process for NHS, but wasn't quite so outstanding. And then organization, the fit with the goals and culture scored very high in the NHS model, but that wasn't reflected. We had kind of moderate scores for our organization in the CSAT. Opportunities for improvement. I think some of the things that we scored the lowest on for the NHS Sustainability Model include behavior, senior leadership. So that was interesting that we had very good support from our immediate leaders, but the senior leaders of our organization maybe didn't know exactly what we were doing. Our immediate supervisors, clinical rehabilitation leadership did. Other opportunities for improvement is communicating our benefits beyond the patients, continuing to be adaptable and flexible, and supporting with the infrastructure that kind of relates to our EMR as well. And monitoring and evaluation was really one of the only things that stuck out as being a very low score for the CSAT. So our scores on the CSAT were a lot higher. As an example, so we did the CSAT online, so I didn't see all of the circles and paper scores coming in, but this is an example of one of the person's ratings, where the only one that comes out pretty low is the EMR. The other ones are, fairly high out of a 7-point scale. So again, there's not, we're looking at both of these tools, and part of our project was really for me and my team to better understand how to use the sustainability assessment tools. And I gained value from using both of them. Obviously, that's redundant. Some people did both of the scores. There was some convenience factor to being able to send a link out to the CSAT. That was really a nice tool, but I felt like the data that we got from the NHS Sustainability Model was more actionable. So then speaking about actionable, that great article that Jillian put together, one of ours, we have a additional file that talks about every implementation strategy that we used in the 2015 to 2016 setup of the initial project, and then our sustainment strategies, which are the 2017 to 2019 period. And in that, because this was published now in 2021, we did bold in that table the things that we are still continuing to do. So we went from a small group of stakeholders and 2 therapists who were really instrumental in putting this project together to we then kind of threw a whole bunch of sustainability strategies. I think we did a lot of stakeholder meetings and periodic assessments, doing a lot of feedback, but ultimately down to 2021, we're narrowing it back down again for continued sustainability. And that includes, it has been institutionalized. We have a PDMD, Parkinson's disease and movement disorders, clinical champions meetings now that are going to be occurring starting actually they were going to start in 2020 to 2021, and then COVID happened, and now the champions are identified. It used to be that we just had a team of champions that were our early PD champions, but now this is being adopted by the organization's PDMD program. And those champions will help with our audit and feedback. So it's not just on our implementation facilitator anymore, it's being absorbed by the organizational's program. We have some more communication things here as well. So these are just the first 3 rows of a multi-page long table that you can look up if you're interested in better understanding the progression of our implementation strategies and their adaptations. So this slide just summarizes kind of our overall program. The benefits are over here on the left, that our organization and staff really support our program. We have institutionalized it and simplified it. We have, although we weren't able to make some structural changes in our EMR, one of our champions up in our suburban site made a really great Excel EMR template that is very, plug and play. It's wonderful. And this is part of the benefits of us including our champions in our project. We have centralized leadership of our PDMD program, which was really great. So I have to thank Dr. Goldman and Sherry Marchbanks, who have adopted the program, I think, as a part of the overall PDMD program. We've added OT and speech therapy care paths to address patients' needs. We have some good support for our patients to improve our scheduling processes. And it's interesting because each of the sites schedules differently. The large academic site actually has more, I think, barriers to scheduling because it uses a large call center, whereas at the smaller community sites, their front desk staff are have much more face time with patients and are, can help a little bit. It can help the therapists a little bit more. We do have challenges for staff, which include, over the course of this 5-year process in a PT rehab setting, there were, I think, 7 babies for the immediate study team. There's a lot of turnover of staff then, not of the core staff, but of the champions that we've trained. And that's just kind of normal job turnover, nothing increased, I don't think, but just it happened. And we did have new leadership, which is both a challenge, but also has been a blessing. And so we continue to have some organizational changes. All other organizations take precedence compared to our small project. All 3 clinics changed locations over the course of 2016 to 2021. We had a pandemic. And then we learned a lot about the process challenges, like avoid starting new programs during the high census summer time. They loved it when we started new things in January when everybody had a little bit more bandwidth. So we're continuing to work through some of those challenges here. So our continued dynamic sustainability include, we have regular reporting to organizational staff and leadership. We're further institutionalizing the program. We have more staff training and empowerment with the champions and kind of letting the champions at our suburban sites kind of go with it and do what's best for their sites without us having to maintain control over it. Although we are monitoring that and making sure that we adapt, because we are, we don't want voltage drop to occur with that additional training, but we think it's going pretty well. We're in, I've had the opportunity to present more about the program to senior leadership, so they're a little bit more aware of what we're doing. And, excitingly, we're also starting to spread and scale it. And I think that also will help to sustain our program. Some of the things that we're doing that are kind of the next steps on incorporating technology. So, remote patient monitoring, I think, is the future of rehabilitation. And I thought I was very validated, like listening to Dr. Chambers talk, because he mentioned, had we developed and maintained things the way that they were in 2005, we would be missing huge growth in technology and development, like the electronic medical records, for example. So I sort of think that digital health technology and remote patient monitoring are going to be incorporated into more healthcare and PT in the future. So we're trying to look at implementation of digital health technology and kind of self-tracking in our program. We are institutionalizing it, including scaling out to new diagnoses like multiple sclerosis. We're developing partnerships and tailoring education, and it is not the same. It's 2 neurodegenerative diseases, but the populations are very different. So it's been really interesting to work on scaling out. And we're also spreading the model of care and disseminating this consultative, proactive rehabilitation model to other centers with Parkinson's disease, other sites. It's the Academy of Neurologic Physical Therapy's Health Promotion and Wellness Task Force looked at this model. So we're really excited to see it grow. So kind of my last summary slide, this is a figure that Jillian put together for our 2021 publication, is really to take our process model that we used in cycle 1, and then we need to add our sustainability goals and our dynamic strategies. We think about the goals in our cycle 1, and we went through a cycle 2 here, and for our second evaluation, we're repeating our re-aim results. We're using our sustainability assessment tools. So this figure shows how it all goes together, a little bit neater than my one that has all 4 frameworks on the same slide. So I have to acknowledge, as I said, I've had funding for this project and related projects in early Parkinson's disease, Jillian McDonald, and clinical leadership at the Shirley Ryan Ability Lab, all of our clinicians and their managers who have been amazingly supportive. This research was funded by Shirley Ryan Ability Lab, the Northwestern University, Northwestern Medicine, and the Academy of Neurologic Physical Therapy, as well as the Parkinson's Foundation. So a lot of support. So thank you all, and I look forward to talking through some of the questions and answers section. Thank you.